All right, thank you. So yeah, it's 12:05 here in Phoenix, and we're going to be talking about focused ultrasound. So I start off with this summary of kind of treatment algorithms for heart arrhythmias, right? I think most of you logged into this are familiar with the brain to a certain degree that we're talking about essential tremor. But to kind of put these strategies in context, um, the way we treat heart rhythms, we try to treat with medicine. Amiodarone's the main medication, cornerstone medication for heart arrhythmias. Cardiologists can do ablations in the heart to disrupt the abnormal circuitry that can cause these abnormal heart rhythms. And everybody knows what a pacemaker is. And these are, again, different strategies: ablation, medication, and modulation for treating these abnormal rhythms. So I am a neurosurgeon, and we have we can consider a similar paradigm for the treatment of movement disorders. So for essential tremor, propranolol is the one FDA-approved medication for essential tremor, and there are a number of approved medications for Parkinson's. And in addition to medication, we too, for these abnormal brain rhythms, have the option of both ablations or pacemakers to treat this. An ablation consists of making a small stroke in the brain, and when done properly, can control movement disorders. And the first part of my talk is going to address that. What you see in the middle here is an MRI of the brain, and this white area right behind the red dot, that's an ablation. That's actually a lesion made using focused ultrasound. And below, you'll see more images similar to this, is a patient laying flat in an MR scanner being evaluated during the process of focused ultrasound, which is what you're here to learn more about today. And then we also have our pacemakers, deep brain stimulation. And so the first phase of my talk is going to be to discuss kind of that evolution of brain surgery for movement disorders that starts with thalamotomy, goes to deep brain stimulation, and brings us back to thalamotomy in the current era. So I'm a neurosurgeon, and I treat movement disorders. So the whole goal here is to improve quality of life. When you think about brain surgery and how the public's imagination has previously been captured by this, we think about brain tumors and aneurysms, ticking time bombs in the depths of the brain, and we think about life-saving surgery. This is life-changing surgery. This is helping people make the decision to choose a surgical option that stands to significantly improve their quality of life, while weighing that compared to the risks of having somebody intervene with their brain. So the standards are very high for safety in this context. The risks must be outweighed by the benefits. So we seek to restore function in this field, and we basically measure our success with how patients report their experience 6 months later. Is their life better? Would they do this again? So what I'll talk about in the next 45 minutes or so is what is a thalamotomy, give you a lot of information about focused ultrasound, and then review the permitted uses of focused ultrasound. So from a historical perspective, this notion of a thalamotomy, what this means is a destructive and ablation of a part of the brain called the thalamus. So thalamotomy is what we're performing with focused ultrasound, which is where we're heading with this talk. But this procedure, a thalamotomy, destroying a portion of the thalamus, extends back to the 1950s. A neurosurgeon, back then they knew that there's different procedures that are doing for Parkinson's. Actually, surgery for Parkinson's extends back to the 1910s. They used to actually go in and sever part of the spinal cord to disrupt the motor fibers to stop somebody from uncontrollably shaking. And that would often be at the expense of movement. They'd become paralyzed instead of shaking. In the 1950s, they discovered that by accident, they accidentally took this artery called the anterior choroidal artery, and this caused a stroke, and they aborted an operation based upon this. And the patient who had Parkinson's woke up not only without a deficit from that stroke, but with benefit. They weren't shaking. And so they discovered incidentally that you could destroy a part of this circuit and stop tremor. So they started doing these thalamotomies, these procedures where they'd ligate, they'd close off this one artery. And sometimes they'd win, sometimes they'd lose. Sometimes the patient would wake up paralyzed, and sometimes they'd wake up intact with a tremor controlled. So it was not a very consistent outcome. From there, they refined the operation to, instead of having to do an invasive operation, making a hole in the skull, passing a probe, probing the area, and then performing an ablation through a small hole drilled behind the forehead. And so that was called a radiofrequency thalamotomy. And so they would use the radio frequency, they basically shake this wire very quickly that would actually have the effect of heating up tissue to the point that cells would die. But first, before they do that, they'd have the patient awaken surgery. So there's a patient awaken surgery with a tremor. They'd drill a hole, they'd pass a probe, and they'd probe the area with that probe to make sure there weren't side effects, looking for the right spot that would control the tremor. And then they'd go past that point of no return, creating a stroke using that probe. So that was done back in the 1960s. The problem about this was that you could only, in this MRI, you can see the eyeballs on the right, this white circle in the middle, that's the thalamotomy, that's the stroke. And it turns out that if you do the same lesion on both sides of the brain, you get side effects you won't get from doing it only on one side. That includes cognition, speech, balance. And so the conventional wisdom was you could only do these thalamotomies safely, unilaterally, only on one side. And in the 1980s, a neurosurgeon had a patient who had symptoms on both sides, like many patients do. And that neurosurgeon basically introduced the modern era of deep brain stimulation by implanting a chronic electrical stimulator. Because at that time, the way these ablations were performed, they would probe the brain in a temporary fashion using electrical stimulation. So they would check, double check, triple check, they were in a safe spot to perform the ablation using electricity, and then they would go on and perform the ablation. And so they basically implanted a brain pacemaker so that the patient would have a chronically implanted electrical stimulation of that area of the brain that they would have otherwise ablated in order to safely treat somebody on their second side. So they had their left hand treated through an ablation, and the first operation using deep brain stimulation was to treat that second side in a reversible manner using electricity instead of an ablation, because deep brain stimulation is not ablative. So this is what deep brain stimulation is used for. It's been used for decades. So we kind of went from the era of ablations, the 1960s, 1970s, to the era of deep brain stimulation in the 1990s. And in the last 8 years, we've been kind of seeing that pendulum swing back toward ablations. I know on virtual meetings, it's often difficult to transmit videos, so I'm not sure how this is coming out to you, but this is an example of deep brain stimulation. That's somebody with an action tremor. Many of you are likely familiar with what this is, since that's the content of this talk. This is an essential tremor. And so it's an action tremor. We often use spirals to measure this. People feeding themselves, applying mascara. That's often the symptoms we're treating with neuromodulation. So he just used the remote control to turn the device back on, and he goes from having this action tremor to having the symptoms controlled. He's able to drink, he's able to feed himself in a way that is non-destructive and is reversible, but requires an operation, requires a device to be implanted, and it requires maintenance of this device the rest of your life, as well as a relationship with a neurologist who can manage this device. So the appeal of deep brain stimulation was its safety, its adjustability, because you can adjust the pacemaker, that it's reversible, and it's non-destructive. It's an electrical therapy. So as a neurosurgeon who implants deep brain stimulation, it's not the operation itself that provides the benefit. It's that when the neurologist turns the device on, it's the electrical titration, just like the medical titration that the neurologist performs to capture these symptoms. So what do you sign up for with DBS? The risk of surgery, you have 4 incisions when I do it for both sides, a lifelong commitment to maintaining this therapy, whether it's recharging the device or coming in for replacements of the pacemaker every sometimes 2 years, sometimes 6 years if you're lucky. And we're committing to a lifelong relationship with a DBS neurologist. Now, with something like Parkinson's, that may make sense because with Parkinson's, you're often best served with a movement disorder specialist. With something like essential tremor, many patients are being treated by their primary care doctors. So they don't have that specialist that they're regularly seeing. And so this is you're kind of going up a level when you're committing to being followed by somebody who's able to program this device. If somebody comes from another state to Phoenix and they need their device replaced, first thing I ask is, who are you established with for programming of that device? So when thinking about these interventions that have been around for decades, deep brain stimulation, it can be thought of as an electrical treatment, but it requires surgery to implant this therapy. The thalamotomy that's been around since the 1950s is a surgical treatment. The neurosurgeon performs the procedure, and when you leave, the symptom is controlled. You can't adjust it afterwards. What the surgeon did is what you get. Focused ultrasound is the next iteration of this history of thalamotomy. And so it is a surgical treatment. It requires a neurosurgeon to press the button that performs the ablation, but it does not require an incision. So that sort of mental hurdle of what am I signing up for when I seek to get better control of my movement is different. It's a different journey. It's a different psychological relationship with the therapy. It is a surgical treatment. You need a neurosurgeon, but there's no incision. So let's talk a little bit more about focused ultrasound. How do we describe it? Incisionless, so no incisions, minimally invasive. I'm always careful of how I use that phrase, because remember that despite no incision, we are killing brain cells, right? Safely and very targeted, but we're killing brain cells nonetheless. And it provides tremor for patients for whom medications aren't working. One of the appeals here is it's outpatient, so you don't spend the night. I've never had a patient spend the night. I'm not even sure what I'd do if a patient needed to spend the night. It's been approved here in the United States since 2016. So that's 7 years now that this has been an approved therapy for essential tremor. And just last year, it was approved for treating the second side. That's unique. So you can actually treat both hands now with this ablation, but it has to be staged by 9 months. We have to separate them by 9 months. I'll talk about that a little bit later. And it's currently being used for Parkinson's tremor, also approved, I think, within the last year. It's not a cure for essential tremor. I think the importance there is just the discussion we'll have a little bit later about recurrence rates. But if there's such a thing as drive-through brain surgery, this is it. I mean, you're coming in, they're under my care for those 2 hours in the MRI scanner, and then they go home, and I did my job, and basically whatever tremor control there's going to be is the result of what I did. How does it work? So you can see on the right, on the top, you see somebody in an MR scanner. There's that little aqua blue helmet, and that's basically the device through which the ultrasound is being delivered through the skull to the brain to perform the ablation. And it turns out using MRI, we can track the temperature of the brain in real time as we're administering the energy using ultrasound. One appeal about ultrasound is it's non-ionizing energy. It's not radiation. It's benign so far as that's concerned. So we use the ultrasound waves that are guided using the MRI to target it to a small area. You think about like a magnifying glass. We use a magnifying glass with the sun to kind of make a leaf go on fire, or I'm not going to get into what people might do with ants, but you can use the magnifying glass to focus the sun rays to basically start a fire, right? So this is doing something similar. It's focusing all these rays of energy in a way that when they culminate at this focus, can create energy to heat the brain cells in a very controlled manner to the point that we can create this ablation without an incision. It turns out that as these rays converge, the surrounding areas don't receive enough energy for damage. And as soon as it passes the target, it dissipates again. So it's very safe to the surrounding tissue. This is a slide from Insightec, that's the company that developed this. It's been around since 1999. And you can see here, the first treatment of a human with an intact skull was in 2005. That was actually for chronic pain in Northern Europe. And then you can see the milestones since then. 2016 was when it was approved, and kind of where we are today with it approved for Parkinson's tremor, for second side. So that's kind of where we are. It's been scrutinized through rigorous clinical trials. These are blinded placebo-controlled trials. That's like as high quality as we get in medicine. So this was a randomized controlled trial. Somebody would actually go with a frame. They'd sit in the MR scanner for hours, not knowing if energy was actually being delivered. So that's a sham controlled trial that showed durable benefit in patients who had undergone thalamotomy, meaning their disability was reduced more, the standard metrics we use to measure essential tremor were improved in a way that was significant compared to patients who didn't, they didn't know if they were getting the treatment or not. And so proof is in the pudding, are you shaking or not? But this benefit is extended to 3 years. And in general, what we're telling people is you're expecting about a 70% improvement in your tremor, and that improvement is durable. We'll get into that a little bit more shortly. So this is what it looks like. This is the Archimedes spiral. This is what we use to kind of assess action tremor. Somebody's trying to make a spiral and they're shaking all over the place. The goal is to stay between the lines. And on the right side, that's the final result after the ablation. For this procedure, because of the way the energy is being transmitted, can't have any hair. So that's one of the prerequisites. We actually shave it down to the scalp. And the stereotactic frame is to ensure that the head doesn't move within that helmet to optimize the convergence of energy through the skull to the target. And then once that's in place, the patient's flat on the MR scanner. They move back and forth about 6 times in and out of the scanner as I evaluate, and I'll talk about those steps shortly. And they're flat for about 1 hour and 45 minutes in my experience. In Arizona, they said earlier, where we were the first site in Arizona to get one of these just a year ago, I was intentionally a late adopter for a focused ultrasound. It went from being a 6-hour procedure to one that we can do within 1 hour and 45 minutes of being flat. And tricks of the trade have been developed over the past 7 years through experience to help mitigate some of the side effects, such as imbalance, by adjusting targeting based upon previous experience. So there's the MR scanner in the back here on the left, and this is the helmet. And this helmet is placed over the patient. The patient actually has like a plastic a band placed over their head, and their head is being cooled by cold water throughout the operation. So this blue can be considered cold water to kind of help cool things as energy is being delivered. So it's the 2 components. It's the MRI scanner that can measure temperature, not just take pictures, and then the helmet that delivers the ultrasound energy. So a review here again of what we're talking about when we say thalamotomy. When you undergo these procedures, it's useful, it behooves you to kind of be familiar with these terms, these medical terms. So thalamotomy is an ablation of the thalamus. This is the old ablation. What we see now, that white dot circle, would be much smaller with focused ultrasound. It's been used for over 50 years to treat tremor. There's many ways in which thalamotomy can be performed. Using that probe by drilling a hole in the skull that I described earlier. Gamma knife can be used for thalamotomy, so that's focused radiation. When you deliver radiation to perform this, it doesn't happen immediately. So you pick your target, you administer the radiation, and at that point, nature is going to take its course. Biology has kind of been provoked, and the tremor does not stop for about 3 months. So it's a less predictable, less controlled manner by which thalamotomy can be performed. And then focused ultrasound is the state of the art of thalamotomy. It is irreversible and it's non-adjustable. So what happens on the day of the procedure, what happens in those 1 hour and 45 minutes that you're flat on the table, what you see is what you get, and there's nothing you can do about it afterwards. It's typically performed on only one side, and the second side has been approved to be performed 9 months later. The purpose of this restriction is to ensure that we know what kind of side effects you have and see where they settle, how they resolve. And say, for example, one were to have persistent imbalance, we would not want to go back and do a second side because that second side would likely worsen that imbalance. So we want to know where we stand after that first ablation before proceeding with that second ablation to minimize those side effects. Because we're doing this for quality of life, the rationale here is that we don't want to substitute one deficit, which is the shaking, with another deficit that may impact quality of life, such as imbalance. Among neurosurgeons, we're careful about referring this as minimally invasive or non-invasive, just because we don't want to diminish how we communicate what it means to kill brain cells using whatever modality we might use. Alternatives include medical management, which is where it's a prerequisite that you've trialed medical management. Deep brain stimulation in the United States, we actually need a reason why somebody's not undergoing deep brain stimulation as a rationale for proceeding with focused ultrasound, and then thalamotomy by alternative means that we've discussed. Your head will be fully shaved. You'll be fully awake when I put this frame on. So see these little white pins? I've applied local anesthetic in 4 spots, 2 in the front, 2 in the back, to numb those areas. And so you're sitting upright. We're communicating the entire time. If you need more anesthetic, I'll give it to you. And it's not that uncomfortable. It's, you think about having your head placed in a vice and sounds horrible, but patients tolerate this very well. And then you'll be in this frame for a couple of hours. As soon as we put this on, we'll put that little plastic cap. The water's going to be rushing through, and then we'll put you flat on the table, lock your head into the table, make sure you're comfortable, put a warming blanket on, for example. And so it'll be, 2 to 3 hours perhaps that you're in that frame before we take it off. The skull does heat up. One of the common experiences that patients have during the administration of the ablative energy is kind of feeling like they're falling backwards or some essence of dizziness, vertigo, while they're sitting there in the scanner. They'll also feel the heat in their skull, and depending upon the quality of skull, and I'll talk about this later too, different amounts of heat may be experienced. It's safe, but it can be uncomfortable, but it also does pass. Patients have a little button, a little bubble, a little ball that they can basically squeeze in their hand, and that can stop the treatment. So by squeezing, you can stop the treatment right then and there, and that's a safety mechanism that we check before we proceed with the treatment. I always advise patients to expect to feel unsteady after the treatment, that I expect that to go away. I tell them, bring a cane, bring a wheelchair, bring a walker. Just don't go into it not expecting this, because it's going to be a little bit unsettling when you have a side effect you weren't expecting. And that is expected to resolve. And that's why I use steroids after the treatment as well, to help suppress some of that swelling that's inevitable with this treatment. So the experience patients have once they go through focused ultrasound, they have that frame on, and then they lay it down on the table. They're basically sitting in the MR scanner wondering, I wonder what's going on, as we're doing a bunch of work in the console planning the treatment. It's a series of steps. First, we get the picture of the brain, and we align it, and we pick our target. Next, we make sure that the spot I see on the MRI, this is the spot I want to hit, matches where the energy is being delivered and where we're seeing temperature changes. So the first step we do is called alignment. And that's where we give a kind of inconsequential dose of temperature. The energy only brings the temperature up to 40 degrees Celsius. And we can see that temperature change on the MRI and determine if we have to shift things around to correct for how the energy is being delivered to the skull and how it's being focused. So we can make these small adjustments using this kind of very kind of mild temperature increase. Once we confirm that spot I'm saying this is where I want to go matches to what's actually getting heated, then we go to a range where we're essentially stunning the brain temporarily. So it's a non-lethal dose of energy. And this is where we check for side effects like numbness in the tip of the tongue, weakness, jarbled speech, as well as improvement of tremor. So we do the exam. And that's when we slide the patient back out and interact and look for benefits and side effects. Once we've confirmed using this verification step, then we go to the ablation, the treatment phase. And at least 2 ablations are performed when I do this. And this is basically where we actually perform the thalamotomy. We do the ablation and interact with the patient to confirm side effects or treatments as we do this. So you can see in this slide that we have the fully reversible zone below 50 degrees. And then the further up you go from 50 degrees Celsius, the more permanent the effect of that energy is going to be. So I discussed with patients in clinic that as you kind of slide in and out of the MR scanner, and we all come in there and we're like, all right, let's check you again. Let's draw the spirals. Let's have you bring a weighted cup to your mouth. Let's test for strength. Let's have you say it's a sunny day in Phoenix, Arizona. So we're doing all this, and I'm trying to extract from the patient any side effects and how they feel about their benefit. If they're sitting there being like, their spiral looks better, but they're like, I'm still shaking, I'm going to think, do I want to deliver an additional ablation? Because I want to satisfy the patient when they get off the table. When they get off the table and they're like, whoa, I feel really dizzy, I don't want to overdo it. So these are some side effects that may be temporary, may be permanent, but these are what I'm looking for, and this is what I'm trying to adjust for through the verification steps. So unsteadiness, dizziness, headaches, nausea, slurred speech, numbness, tingling, loss of taste or smell, recurrence of tremor. Sometimes people have like a metallic taste in their mouth after this procedure, for example. They usually don't notice that during the verification step. I've had one patient who noticed it afterwards. So feedback, that communication is important. So that's kind of a general idea of what it looks like to undergo this therapy. Beforehand, I usually ask patients, especially women patients with their hair, get a haircut, get it taken down, the night before. That kind of reduces the amount of work we put into kind of getting all that hair off. And then on the day of the treatment, we'll kind of go a little bit further and take it all the way to the scalp. Don't take your medications for tremor the night before, the morning of treatment. Blood thinners, there's a whole spiel about blood thinners, but you want to be off those blood thinners for a few days before the treatment. The risk of bleeding is very small, but we don't want to provoke bleed by having a lower threshold for bleeds due to blood thinners. There's a few medications I usually use, Tylenol, Decadron, which is a steroid, and Zofran, which is for nausea. I give those to you before the treatment. We also have you go to the bathroom, last thing we do before you roll back into the scanner. We use the local anesthetic. That's basically all I use for pain. I don't do IV pain medicine for this. I only use the Tylenol. And first and foremost, we don't want any medication that's going to suppress the tremor because we're chasing your symptoms during the treatment. So we'll numb up the scalp, and there's no anesthesiologist with me. You won't be having any sedation. So just kind of that awareness of kind of what it's going to be like. And so you're not surprised on the day of treatment that it's more than you expect. It's not like the triple corkscrew, double loop roller coaster, but it's still something that you got to be prepared for. We'll talk about claustrophobia as well, but there are contraindications. You need to be able to participate with the therapy, and part of that is being able to tolerate being in the MR scanner, and it's not an open MRI, so claustrophobia would be a contraindication. So after the treatment, I give some more steroids. It's a Medrol dose pack. You start with six pills the first day, 5 the next, 4, 3, 2, 1. That's again to help suppress some of these swelling symptoms that may be associated with the ablation. Always be prepared for some balance. Don't put yourself in harm's way. Avoid falls. We have some Band-Aids that we place, those come off, and I would advise no driving for 2 weeks after the treatment. So here's some indications. Essential tremor. So tremor that cannot be controlled with medication. We have quantitative ways to measure tremor that we report in our notes to get approval by Medicare. We do one set at a time. Patients must be a minimum of 22 years of age. We also are approved to do this for tremor dominant Parkinson's disease. It only helps with the tremor when we treat the tremor target, doesn't help with the other symptoms. There's also other approvals for Parkinson's, like a pallidotomy. Pallidotomies were performed widely in the 1990s. It's an ablative procedure that's done on one side that can treat the stiffness, slowness, in addition to the tremor. And we continue to see evolving and advancing approvals for different indications for movement disorders. Say you're shaking, but when you start talking, your shaking goes away. That's there's ways that essential tremor that neurologists can tease out different forms of tremor. That would be like a functional tremor. Sometimes it is in your head. Like it's something that if you can be distracted from it, it may be coming from some other source, not from an essential tremor dysregulated circuit. So having confirmation that it is indeed an essential tremor is critical. We don't want to do ablations for something that's not going to respond. We look for at least 2 medications that have failed. These are standard medications, propranolol, primidone. We talked about the age. You need to be able to lay flat for 2 to 3 hours. If it's too much back pain, right, that would be a problem. And then I'm going to talk a little bit about the CT scan requirements. That's a screening step. We get a CAT scan of your head to look at your skull to screen for whether your skull actually allows for this energy to be delivered through the skull in the magnifying glass kind of way to target the thalamus. And we always look for one kind of note to describe why DBS is not an appropriate treatment for you. So having some kind of understanding of that is important. So, when you look at fish underwater, there's, people put on polarized glasses to be able to see through the water so their vision can go through. And often, where you see the fish is, it's actually different from where the fish actually is. That's called refraction. Same thing when you shine light through a prism, it separates. These are kind of ideas that I use to kind of describe what happens as the ultrasound energy hits the skull. Now, the skull is not just uniform thickness. There's a hard part that's on the outside and the inside. That's called cortical bone. In between, it's called cancellous bone. And the skull density ratio is basically a measure that the company that makes the device measures for us, that basically describes the variability of density of the skull from outside to inside. And if there's too much variability, it's almost like throwing a rock in the water, and all of a sudden you get this ripple effect you can't see underneath. And as things settle, you can see it. It basically, if you have too much variability, there's too much reflection and refraction going on with the energy that it ends up being impossible to get enough energy to the target in a way that can heat the tissue up efficiently. So we use this as a screening tool to see if a skull is compatible with the needs to administer the energy in an efficient manner. Inefficient delivery would mean really heating up the skull because of the amount of energy being absorbed or reflected by the skull. And basically it ends up being where it's completely, it's something you would not be able to tolerate in the MR scanner to undergo this, because essentially the impossibility of being able to get that energy and focusing enough energy to heat the tissue in a way required to perform the thalamotomy. So this is a step that is basically can disqualify you from, so we like thick skulls. Thick skulls are good. Dense skulls, and that's a measure that we use, and Medicare's actually used that as a qualifying value for focused ultrasound. Claustrophobia. I've done a number of patients with pacemakers that are MRI compatible. We navigate this with cardiology and with the devices, but there are many devices that have been implanted that you can't get an MRI with. If you have an implant that prevents you from getting an MRI, you can't get focused ultrasound. History of falls, again, you're going into it expecting and consenting to the risk of a worsening of balance and acknowledging that you're likely to at least have some temporary imbalance. So history of falls can be a relative contraindication of this. We talked a little bit about DBS versus focused ultrasound. I'm not going to get into this slide, but I'll have one of my last slides talks about this a little bit more. It is covered by insurance in the United States, and every few months we find that insurance is covering another aspect of the approved therapy. In the United States, first we get FDA approval, and then we wait for insurance to actually agree to pay for this. So while, for example, this was approved for Parkinson's tremor a few years ago, Medicare just started covering it this past summer. So some concluding thoughts. This is an exciting time. Essential tremor is the most common movement disorder in the world. It's something a lot of people develop like in high school, and it's something that they learn to live with. So even though it may be obvious and people think they're nervous or they have Parkinson's, I have a lot of patients who say it bothers it bothers other people more than it bothers them, right? So when you kind of look at the volume of patients with essential tremor, the number that actually would stand to benefit who would want more treatment than they can get with medicine is about 60,000 patients. That's a lot of patients. The story with what neurosurgeons do for movement disorders is one of underutilization. Far more patients stand to benefit from these treatments than who elect to undergo these treatments. A lot of that can be the fear of surgery, right? Or the fear of, just dealing with the neurosurgeon. And that's been one of the biggest challenges with deep brain stimulation. What's really exciting about focused ultrasound is that our experience with this therapy is that we've seen how accessible this therapy is to patients. They're more likely to say, hey, sign me up for this. I want to stop shaking, than they are with deep brain stimulation. It's a different psychological journey patients undergo as they decide they want to do something about their shaking. So there's a huge growth opportunity with focused ultrasound just by virtue of the sheer numbers of patients out there with essential tremor and those for whom medications are not enough. We've seen enormous growth with this over the past, since it's been approved. It's spreading like wildfire. You know, one of the things I say about deep brain stimulation, it may be new to you, but it's nothing new. This is not a treatment of last resort. It's not experimental. And the more it grows, the more patients can be rest assured that they're just joining the club of, you know, thousands and thousands of patients who have undergone this because they're tired of shaking. It's the buzz. I mean, it's the future. We know it in our field, and it's exciting to give patients a more accessible path to having these treated in a more definitive manner. So far as focused ultrasound versus deep brain stimulation, I do more DBS than I think anybody in the United States, one of the highest volume DBS surgeons in the world. I kind of tap into that experience of looking at that same side of the brain that I use for deep brain stimulation to treat with focused ultrasound. So I brought that experience in when I started doing this, doing focused ultrasound a year ago. And it's been a completely different experience to see that how patients respond and how they go through this journey compared to deep brain stimulation. My experience so far is that the patients seem to be older at this point than deep brain stimulation patients. Age would be a reason not to get DBS, and blood thinners would be a reason. It's never been compared to head with DBS. So focused ultrasound has not been compared directly with DBS. So we can't say which one works better than the other. I use 85% improvement of tremor for DBS, and I think we generally say 70% improvement of the tremor with focused ultrasound. That improvement doesn't necessarily correspond with satisfaction. I think that the focused ultrasound patients are very satisfied, and I think that it's kind of like what you sign yourself up for what benefit. And I think that the experience of not having to undergo through surgery, not having the device you have to maintain, it's different expectations. And so the focused ultrasound patients have a durable, significant improvement in their tremor that they find very satisfying. But we can adjust it. But I think also similarly, I think people are more likely to sign up for focused ultrasound than DBS because of you don't need an incision, you don't need to commit to a lifelong maintenance of this therapy, you don't need to commit to a lifelong relationship with a movement disorder specialist in order to undergo focused ultrasound. One thing I always emphasize in clinic, it's better to undertreat than overtreat. So I don't guarantee that we're going to get 100% improvement of the tremor. And if you have recurrence of the tremor, I can go back and make a larger lesion, or we can always do deep brain stimulation, but I can't undo side effects from making too large of a lesion. So there's that judgment, right? That by interacting with you while you're on the table, when do I stop? I'm better off finding a satisfactory tremor at the time of the treatment and then it recurring in a few months and we go back than having a side effect that I can't reverse, such as imbalance, speech, numbness. So that's the basic principle you sign up for with a surgeon, is they err on the side of undertreatment than overtreating because we can't undo overtreatment. So I think we have time from here to have a discussion. I'm happy to answer any questions. Thank you very much.
Thank you so much, Dr. Ponce. That was wonderful. And thank you everybody for your great questions. So I'll go ahead and give you a couple of questions and we'll get started here. One of the questions is, what is the prevalence after you've had the focused ultrasound of balance or dizziness as a side effect? I know you said it could happen obviously right away, right after the surgery, but post-surgery, weeks, months from now, what's that prevalence?
I think if you got physical therapy to look, you'd probably see, about 10 to 15% of patients have some element. I think in terms of something that's functionally significant that kind of offsets the benefits they receive from focused ultrasound. I don't have the data right in front of me, but I'd expect it to be about 5%.
And the next one is how long before you have to do the medication trials before you can be a candidate?
Yeah, that's a good question. I think you want to know. I think that's where it's good to be with a movement disorder specialist, because they can say, right, let's not dilly-dally too long with medication failures. Let's get into it. Let's see what the how you do with propranolol. Let's see how you do with primidone. You know, if you have side effects like your blood pressure gets too low, your heart rate with propranolol, let's move on. I think that's where a lot of patients get held up with throwing the kitchen sink medically. You know, they take seizure medication and they're foggy, foggy brain. So I think that it's there's an art to the neurology side of this, where and even primary care. So I think that the journey most patients have is one where it makes a lot of sense to trial the medications. So I don't think that there's a clear line of the same like we see with Parkinson's and DBS, where we can say a little bit more like, hey, let's make sure that we have 4 years of medication responsive symptoms, and then 4 months that we're chasing symptoms by making adjustments because of fluctuations. We don't have as clear of a line because of the journey that patients have with essential tremor, where most of them choose to live with it as it's mild, and then as it progresses, the default seems to be that they've been chasing this for a while, as opposed to somebody's like, I'm shaking. How much time do I have to pay? Into like medications before I can get this focused ultrasound. So I think that it's I think probably at least a year of experiencing it. I just think that the patient journey is such that we usually see them having had this for a bit more time than that.
Okay. And if you have the focused ultrasound at some point later, if you're having the focused ultrasound for the Parkinson's tremor, if sometime later you are really needing maybe DBS for other symptoms of Parkinson's, can that be done?
Yes. So once you've had focused ultrasound, you can undergo DBS. And absolutely, if you get something like that there's 3 different nodes in these circuits that we use in deep brain stimulation. So and 2 of them are approved for focused ultrasound. So we could go to the same node. We could go to a different node. Obviously, if we do the essential tremor target for Parkinson's, which is approved, we could go to the other target that helps with slowness and stiffness. So yes, one thing I would counsel is that the thresholds for side effects may be lower with deep brain stimulation if there's also an ablation, if there's also a thalamotomy. So if you get focused ultrasound and then you add DBS, there's side effects that I like describe as being normal, like, oh, you have some verbal fluency side effects with DBS for Parkinson's. We know that, we know that happens, and not to a degree that people opt not to have the therapy, but we know that these are part of the circuits that are also impacted by Parkinson's disease. And I think in the setting of somebody with Parkinson's or essential tremor, if somebody were to proceed with DBS, whereas side effects from DBS are often you can turn them off, it's reversible. And we may be a little bit more up against a wall where you turn the DBS on slightly and you notice side effects because of the interference already created by the ablation.
And then on speaking of voice, does the focused ultrasound help if your tremor affects your voice, your shaking?
Another great question. It's funny, I deal with a lot of these questions in the context of deep brain stimulation, and deep brain stimulation is something that we do bilaterally from the beginning, right? And whenever I talk to somebody about head tremor or voice tremor, I emphasize what the FDA has approved for this to be used for, and that's appendicular tremor. That's a hand tremor, right? So, and I have some patients whose voice or head tremor bothers them more than their hand tremor. And so I always kind of narrow the scope of expectations in that context. And I feel pretty confident with voice and head with deep brain stimulation when you do bilaterally, but I still temper expectations because I don't want people to sign up for something that when the FDA says like, well, we have data for hand, but we don't have the data we need to make a statement on voice or head. With focused ultrasound, I would not expect improvements with voice. I think that we may see it, but because of the side effects that can occur with voice and the irreversibility, lack of adjustability, I would take that as icing on the cake if it were to occur, but I wouldn't go into it expecting that as sort of a soft indication for focused ultrasound.
Okay. Will you still need to take medicines after the focused ultrasound?
So far as taking medicine after focused ultrasound, my goal would be that patients don't have to take medications afterwards. Sometimes it's the question of like, say you have 15% of your tremor residual and medications help that 15. Well, I always say shoot for 70% improvement with focused ultrasound, shoot for 85% improvement with deep brain stimulation. Don't expect 100%. Now so if you have that residual, right? If somebody's shaking like this and they get 85% improvement, that's pretty good. They can use a screwdriver. If somebody's shaking like this, you shave off that degree and they may still not be able to use a screwdriver. So in those situations, the medication may kind of give them an extra, 5-10% improvement that they find worthwhile. Versus they're shaking like this instead of wildly, and they choose to not take medication. So that's often a decision that's going to be made with the primary care doctor or the movement disorder specialist, and is up to the patient. I have patients for whom the medication is not doing anything, and they come and see me still taking that medication. So I think that there's an art to kind of what the neurologist chooses to do. And I think expecting to have 100% improvement with focused ultrasound and being off medication may be unrealistic. I think it's a balance, but most patients, I think, will choose not to take medication after focused ultrasound.
Dr. Ponce, just a quick clarification. Is that also true for Parkinson's, tremor-dominant Parkinson's? Like carbidopa, if they're on carbidopa-levodopa?
Yeah, with carbidopa-levodopa, with Parkinson's disease, when you do deep brain stimulation, we target this area a different area called the subthalamic nucleus. And there we see very dramatic reductions of needed carbidopa-levodopa. If you have tremor-predominant Parkinson's disease, you need the carbidopa-levodopa to control the bradykinesia, the slowness, and the rigidity, the stiffness. And so if you think you can get off of that because it's doing something but not much for your tremor, you may notice when you get off carbidopa-levodopa that one, you have symptoms on the other side of the body, right, that you didn't notice while you're taking those medications, or two, that the bradykinesia and rigidity that you weren't thinking much of now becomes more of an issue. So I would expect that patients would remain on carbidopa-levodopa after focused ultrasound for tremor-predominant Parkinson's. Thank you.
Now this one's a little bit more geared, I guess, towards our practices here. How many focused ultrasound cases have you done, and what would you consider the percentage of the success rate?
I've done about 25 patients so far. I've had 2 patients that I've taken back for a second lesion. I think the first one was one of my second or third patient. And that's basically when you think about going back, it would be because they weren't satisfied with the degree of tremor control at follow-up. The side effects, I've had a patient with Parkinson's disease who had this done for Parkinson's tremor, and that patient had more imbalance than longer lasting imbalance, and that may persist. Of the essential tremor patients without Parkinson's, it's been transient imbalance. And that's kind of the scope of, and when I first started, one of my colleagues was like, always warn about imbalance. Like that's the one thing you want to get in their head with. And so I've been very vigilant about counseling about that, but that would be it. So that's been the experience thus far in our Barrow program. That's almost a year old.
And then does it work with with a tremor that's related to a Parkinsonism versus just a Parkinson's or an essential tremor?
Good question. So Parkinsonism is different than Parkinson's disease. So that would be an off-label use. So a patient with Parkinsonism that wants DBS for their shaking, deep brain stimulation, would probably not get it. We don't do DBS. We need essential tremor or we need Parkinson's disease. And if we don't do those for those indications and Medicare comes and does an audit, they're going to ask for their money back. That would be an off-label use. And again, that would be something I would only feel comfortable considering if it was coming from, if the referral was coming from one of my trusted movement disorder specialists that I partner with, neurologists.
And then how long should they expect the tremor to be controlled with this focused ultrasound? Is it something that in 5 years they're going to have to go back? Or what do we think the lifespan of this surgery is going to be?
Yeah, I think we're still learning that. I don't think that the history is people coming back after 3 to 5 years. That's not like the treatment strategy. I think people still have a meaningful improvement. About at least more than half of patients have meaningful sustained improvement at 3 years, and that's in the sham-controlled randomized trial. That's from the 3-year follow-up from the pivotal study. So I think the goal is, a durable lesion. You don't have that adjustability that you do with DBS, and we just don't have the data to be able to really say this is what we'd expect, 10 years down the road.
Yeah, that's what I figured. Do you feel like focused ultrasound is the future of addressing tremor, where you would expect maybe less DBS in the future for tremor control and more focused ultrasound? Think that's kind of where we're headed, or?
Yeah, I think so. And I think a lot of that just has to do with what it means when you're diagnosed with essential tremor versus what it means when you're diagnosed with Parkinson's disease. It's a very different life event, right? Oh, I got essential tremor. Okay. That's, I was shaking in high school. They called me Shaky Joe. I think that what somebody who's shaking when somebody with essential tremor is looking for is more in line with what focused ultrasound offers. Whereas with the Parkinson's journey, where you're diagnosed, 4 years later, you're dealing with, side effects of medication or shortcomings. 7 years later, you're taking medications every 2 hours, right? And you're up and down. You can't predict when you're going to be, your symptoms. It's a very different experience. And so those patients, I think, even though the visual effect of deep brain stimulation on essential tremor is so dramatic, I find the Parkinson's patients much more satisfied consistently with DBS because of what it means in their journey with Parkinson's. Whereas essential tremor patients, they're not saying I'm not there yet. They're saying this is not for me. No one's going to drill a hole in my head. And so I think this has a huge future for essential tremor. And many of my mentors, those are a generation ahead of me, regard deep brain stimulation as sort of the process, the journey we took to going back to ablation, where we know where to make the ablation better than we did 30, 40 years ago. And we have more control of that ablation than we did with the previous techniques. So that DBS helped us refine our techniques so we have a better understanding of where to land a small ablation compared to the big ones that we did back in the 1980s.
Wonderful, wonderful. So there were a few more questions, and we will get back to everybody on those offline. Thank you so much for submitting them. We appreciate them. And thank you so much, Dr. Ponce, for today. It was very educational. I would like to give Cindy an opportunity for those that would like to make an appointment or to learn how can they be referred to get to focus ultrasound if it's something they do want to do. What do you feel, Cindy, is the best procedure to do that?
Best way to do that would probably be either to give me a call at the phone number, and I think, Chris, you're going to put the number up for everyone?
Yes.
So you can call, leave me a message on that number, and I will get back to you. If you have a neurologist that you're working with, that's great. If you need a neurologist, I'm happy to connect you with one here at Barrow. But it does need to be a referral from a neurologist, not a primary care doctor. So yeah, you can do that, or you can send me an email through the info@barrowneuro.org.
All right, thank you. I just put those in the chat for everybody. And like I said, afterwards, I will go ahead and send that out to everybody who attended today as well, that information along with the website, so you can learn more about it. And thank you so much. I appreciate both of you coming on and talking. How very exciting what the future is holding for us for the treatments for tremor. So thank you.
Great. Thank you.
Thanks, Chris. Thanks, everyone.